So Dr. Dika is a board-certified dermatologist specializing in skin cancer prevention, detection, and treatment, as well as the management of complex medical conditions such as psoriasis, eczema, rashes, acne, and more. She sees patients of all ages and all skin types. As a provider, Dr. Dika strives to provide a trusting environment where her patients can feel comfortable opening up about their concerns. Dr. Dika obtained her medical degree from the Medical College in Wisconsin, and she graduated in 2015. She now runs her own practice in Burlington. So welcome, Dr. Dika.
Can you hear me?
Yes.
Thank you, Mary, and thank you everybody for joining us. Thank you for having me. So I'm going to go over a few facts about skin cancer. What is skin cancer? So skin cancer happens when the cells of the skin become abnormal and eventually form a tumor. The three most common skin cancers are basal cell, squamous cell, and melanoma. Skin cancer in general is the most common type of cancer, basal cell being the most common. And as you can see on this graph, the skin has two layers. The top layer is called the epidermis, and then the bottom layer is called the dermis. So most skin cancer originate from the epidermis, and then they grow downwards. So the bottom layer of the epidermis is the basal layer. So that's where the basal cell carcinoma originates from. As the skin cells are called keratinocytes, as they mature, they go upwards in the skin. So the ones that are a little bit higher are called squamous cells, and those are the ones that give squamous cell carcinoma. And then melanocytes, which are the pigmented cells, usually resides are scattered along the basal layer of the skin. So those ones are where the basal melanoma originate from. Even though melanoma is the least common type of skin cancer, that's the one that is most dangerous because it can spread to other vital organs. We can go to the next slide. So this is a slide or a graph that I got from the CDC website. It just provides some statistics about, skin cancer in the United States. Just as I said before, skin cancer is the most common type of cancer. Every year, about 5 million people are treated for skin cancer. And then it says down here that 9,000 people die of melanoma every year. So that's a high number. And it costs our economy about $8 billion to treat skin cancer. So what are the risk factors of skin cancer? I would say the most preventable one is UV, A and B radiation. So although some people are at higher risk of skin cancer, anyone can get skin cancer. The other risk factors that we usually note is, people that have lighter skin color, blue or green eyes, blonde or red hair, the skin that burns easily, people that have freckles, people that have, the skin kind of gets red and tender with sun exposure. The older you get, your skin is more prone to developing skin cancer. Also, anybody that has a personal or family history of skin cancer is a high-risk patient. Having moles itself doesn't mean that you have you can have skin cancer, but the more moles you have and the more abnormal or atypical moles you have, puts you at high risk of developing skin cancer. And then with UV radiation, depending on your skin type, right, you react differently to the sun. UVA and UVB are the most damaging rays that cause damage to the skin, and they do that by altering the DNA of the skin cells, and that damage is what causes the changes that lead to aging of our skin and then skin cancer. And there are a few myths out there that are not true. One is that a tan causes indicate good health, meaning if somebody tans, they're like, oh, I'm fine, I don't burn, I tan. Any tan on your skin indicates that you've had damage on your skin. So tanning is not a good thing, or the ability to tan is not a good thing. And also a base tan does not protect against sunburn. So some people think, oh, I'm just gonna get a little bit of tanning, so I'm not gonna burn. Again, that is not true. Okay, so this is an interesting image. It's been around for a while. So this was just a standby, somebody that was just walking on the street and then saw this man. This is a British man with 28 years of working as a truck driver. And you can see on his left side, which is the side that is exposed to the sun, he has so much damage, or like the skin is more aged compared to the right side. So these are the effects beyond skin cancer that the sun has on our skin. And then here I have some images of my patients, actually. This patient to the left, this is a lady, African-American actually, in her early 40s, who presented to me with a growing lesion on her forehead for over a year. And then she noticed that it was developing some dark spots in the middle of the lesion. And then the patient in the middle, I saw him in July, and at that time there was nothing on his forearm. So he came to me early this month with a red bump that started thereafter and then had gotten bigger over time. And the other patient here on the far right is a gentleman with a histomelanoma, and his last skin check was about 5 years prior, so 2017. So we did a full skin check, and he mentioned that he had this lesion on his left forearm for years now. It was fine, and all the other dermatologists had said it was fine. However, recently the lesion had gotten a little bit darker. So that's kind of why he brought it up to me. So with that change, then we have the ABCDEs of melanoma, which is really important acronym. So it kind of helps you decide whether a lesion is something that you should worry about or you should have checked or not. So A stands for asymmetry. So if you have a lesion, the question is, does the mole or the spot have irregular shape with two parts that look very different? The borders, or B stands for border, is the border irregular or jagged? C stands for color. Is the color uneven? So do you have one spot side of the lesion darker and the other one lighter, or one is pink, the other one is dark? D is for diameter. So the mole size, is it larger than a P? Or usually we say the back of the pencil eraser, or 6 millimeters. So if you have a mole that's bigger than that, that's sometimes a kind of a warning sign. And then E, in my opinion, is the most important one, evolving, the history. So how long have you had it? Is it changing? Is it itchy? Is it bleeding? Is it growing? So those are the signs. Again, all these three patients have that E in common, even though they don't all have melanoma, they all have that E. So for her, again, she's had it for a year, but it's getting bigger. For him, it's been 3 or 4 months, but it's bigger, redder, tender. For him, again, he's had it for years, over 3 years, or over 5 years since the last time he had his skin check was 5 years ago, but it's gotten darker in the middle. So those are, again, signs to kind of to watch out for. This patient, sorry, can you go back to the other side? So yeah, this lady, her spot came back as a basal cell. The man in the middle, his came back as a squamous cell, and the patient on the far right, it was a melanoma. Okay, so what are the ways we can lower our risk of skin cancer? Like I said earlier, UV exposure is the most modifiable risk factor. So that's something that we can do something about. We can't do anything about our skin color or the color of our eyes. However, we can protect ourselves from the UV rays. So simple things are, when you're going out, make sure you always seek the shade, right? You don't want to be directly under the sun. So especially between the hours of 10 to 4, you're going to read somewhere it says about 10 to 2, but usually we say to be safe, you want to make sure between 10 to 4, that's when you have the most intense rays. Using sunscreen, lip balms. There's some lip balms now that have SPF. I think Eucerin has a lip balm with SPF vanity cream. So a few brands out there have that. Wearing a wide brim hat, just like the picture here, so that you have protection for your ears as well. We're applying sunscreen every 2 hours. very important. If you're out for more than 2 hours, it's important to reapply. If you're going in the water, you're swimming, as soon as you get out of the pool, you want to put your sunscreen on. If you're sweating too much, right, the sweat is kind of washing off your sunscreen, you want to reapply. Sunglasses, and then so they have some shirts now that have SPF, so long sleeve shirts, and then even swimsuits. Some swimsuits these days have SPF. All right, so this is kind of a little bit of talking about sunscreen. When we say sunscreen, you have to know what type of sunscreen to buy. Broad spectrum is what you look for. Broad spectrum meaning you're getting the protection from UVA and UVB, because the rays that damage our skin, as you see in this diagram, you have UVA and UVB, and UVA penetrates a little bit deeper than UVB, but you want to make sure that you have a sunscreen that has protection for both UVA and UVB. Important also, SPF. 30 is the minimum that I recommend to my patients. The higher the SPF, the better. So the higher, the more protection you're kind of providing your skin. And also we divide sunscreen into 2 categories. Either you have physical blockers or mineral sunscreen and chemical blockers. So the physical sunscreen or sunblock basically prevents the ray or the UVs from getting into your skin. So it just deflects the rays. Those ones are zinc oxide and titanium dioxide. And most people can tolerate that in the sense that it usually causes less risk of causing any allergic reaction. The only thing with the physical or mineral blockers is when you put it on, sometimes it has like it leaves like a white residue on the skin. So it's kind of aesthetically not the most appealing type of sunscreen. But now they have the ones that are a little bit more sheer, so it's a little bit easier to kind of blend it in. And then you have the chemical sunscreen. So basically the UV rays are absorbed into the skin, but then the sunscreen kind of prevents it from becoming harmful to the skin. Those ones, they are also good, but some of the ingredients some patients can react to some of the ingredients. So that's kind of the difference. So, but any sunscreen that you can tolerate, that you can put on, is what we want you to use. Okay, so screening recommendation for skin cancer. I say anybody who is over, I would say 60 should get a skin cancer screening. At the age of 65 and above, that's a yearly recommendation. And this is a covered benefit by Medicare. So anybody that's over 65 should get a yearly skin check. As far as, the younger population, if you have a risk factor, then you should get a baseline skin screening, meaning, again, if you have had yourself a skin cancer, or let's say your father had melanoma when he was in his 30s, that's a young age to get melanoma. So that means you should get a baseline skin screening. Or if you're on a medication that suppresses your immune system, chemotherapy or anti-rejection medication, or if you have a cancer, right, that is kind of lowering your immune system. So I see a lot of patients that come in because they're referred to me by an oncologist to have a skin screening because they're on specific medication, just to make sure that the medication is not altering the ability to fight skin cancer. Around late 20, early 30, if you get one screening and we notice that there's nothing worrisome, usually we say you can come back every 3 to 4 years just to check back in. When I see folks that are older, I do a skin screening. I say, see you back in a year or sooner if you notice something. Just like the patient that I talked about earlier, who I had seen in July, and his appointment wasn't supposed to be till next year, but he noticed something that was changing. So then he knew to call us and schedule another appointment to have that spot evaluated. So basically, as long as you know the warning signs and as soon as you notice something that you're worried about, you should come in right away. Otherwise, any risk factor should be right away baseline, and then the dermatologist would determine when you should come back. Okay, so when you come in and we find something that is concerning, how do we manage it? So we usually do what we call a skin biopsy. So for diagnosis, we usually do either a shave biopsy or a punch biopsy. So you come in, we look at the spot, and I usually take a photo of whatever area I'm going to biopsy, because we always want to keep records of stuff. And then if you want to kind of monitor the progression. So the area is cleaned with alcohol, and then we numb it. And then for the shave, you use a blade, just like in this image, to take the sample. Otherwise, we do a punch. With the punch, we use something that looks like a cookie cutter. We take the sample, and then we have to stitch it. And now it's like, when do we shave? When do we punch? So the only time we we do a punch biopsy is when we are worried about melanoma. Because for melanoma, the staging of melanoma depends on the depth of the tumor. So how deep does it go in the skin? So that's why we want to make sure we go to the deepest layer of the skin, get all the full layer of the skin for the pathologist to examine. So that's when we do a punch biopsy. So when we do the punch biopsy, again, we don't process the tissue the same day. So it takes about a week to get the result. Once we have the result, then we plan for treatment. The treatment options that are most commonly used, depending on the stage of the skin cancer, are sometimes we do what we call a scrape and burn, where you come in, we draw a circle around the lesion, and then we take a normal skin. After we numb, of course, we use a curette. As you can see in that picture, we scrape off the skin cancer. You're probably going to wonder, how do we know? The skin cancer is very friable. So when you scrape it off, you can see it comes off easily. So you scrape it until you feel like, okay, I'm getting to the normal skin. And we have cutaway. So we burn off the skin again, we scrape it. So we do 3 rounds of what we call scrape and burn. So usually we do that for superficial basal cell or squamous cell carcinoma in situ, which is also superficial. So superficial meaning it's only on the epidermis, the top layer of the skin. It hasn't gone down to the dermis. Otherwise, if it's what we call invasive skin cancer, then we're going to do an excision, which is the picture here is an ellipse. So what we do is we draw around the normal the skin cancer. We take some normal skin around it, which is called margins, just because we want to make sure that we don't leave any of the cancer cell behind. And then we have to extend it in opposite ends to form like football shape, so that when we close it, we stitch it, it closes in a straight line. Otherwise, if it's a circle, we won't be able to close it stitch it in a straight line. The last method here is Mohs micrographic surgery. That one is usually done for skin cancer that are in areas where we don't have enough laxity, enough skin. So usually anybody with skin cancer on the face that is too big of a size, or the scalp, then we do Mohs surgery. So it's a step-wise like procedure. So they take layer after layer, smaller. So instead of taking a large margin like an excision, like you see here, they take maybe 1 millimeter around the skin cancer. They have you wait, they process the tissue right away. And then if the margins are positive, then they bring you back again, take a little bit more tissue until the margins are negative before closing. And this is also done by a dermatologist, but they have extra training. So they spend an extra year just performing or perfecting this skill. So done by a dermatologist, but I don't do that because I don't do that surgery all the time. So usually when I get a patient that need that surgery, I either refer them somewhere else, or starting January, I'm going to be offering it in my office, where I'm going to have a colleague come in and perform the surgery, the procedure in the office. Okay, so for the 3 patients that I showed initially, so her lesion, again, being that it's on her face, on her forehead, and it's a really big lesion, if we were trying to do an excision, there would be no way for us to close in a straight line. So she had to undergo Mohs surgery. And then after they do the Mohs surgery, based on how big the defect is, they decide how they're going to close it. Sometimes they do a graft. Sometimes they do what we call a flap. So where they're going to cut the skin all the way down here and rotate or flip it around so it can close the defect. But they can do it the same day, or sometimes they have the patient clear the skin cancer and send the patient to a plastic surgeon to close it. The patient in the middle, he had a regular excision, and then the patient on the right also had a regular excision. difference between the middle and the right is the scar is going to be longer for the patient on the right side because it's a melanoma. Because it's a melanoma, we take a bigger or a larger margin. So the circle is going to be bigger for the patient that has melanoma. So hence, he's going to have a longer scar when he's done. Once we do the skin cancer surgery, then we have recommendation for follow-up. So for non-melanoma skin cancer, which is basal and squamous cell, it's every 6 months for a year. And then thereafter, if they don't have any new lesion, then we go yearly. However, that clock is going to reset if we diagnose a new skin cancer, then they have to come back again 6 months. Patients that have melanoma, provided they don't have any involvement, any vital organs, there's no metastasis, then we do every 3-month skin check after the diagnosis for a year, and then every 6 months for another year. If everything is fine during that time, the first 2 years, then we go every year. So this patient that came to me when he hadn't had a skin check for 6 or 5 years, that was way too long of a gap in between. Actually, I have a very sad case where I saw a patient 2 years ago. She called the office because she thought she had eczema on her forehead. And then when she called, she was like, oh, by the way, I also want a skin check. Well, they told her, oh, yeah, we can do this 2 of those at the same time. Then when she came in, I realized that it wasn't eczema that was on her forehead. It was more of an autoimmune disease. So that took us about 30 minutes just to figure that out. And then at the end, she's like, well, what about my skin check? So because I was pressed for time, I told her, well, we're going to have to reschedule that. But you let me know if there's one specific lesion that you want me to look at. So she had me look at a couple of moles, and then she had me look at her armpit. She had it like almost like a golf ball size, like lump in her armpit. So when I examined that, I was like, that is not a cyst. I think it needs to be imaged before we do anything. Come to find out, she had a history of melanoma, and she hadn't had an examination by a dermatologist in over 5 years. She was just going to her primary care for regular annual check. So I got a call 2 days later that this lesion that I recommended to be imaged came back as a metastatic melanoma. So her melanoma that she had years ago kind of had recurred, but because nobody had been keeping an eye on her, it went undiagnosed for a while. So, but then she had to go through, figure out how to manage now the recurrence. Okay, so we're not saying that you shouldn't go out and enjoy, your time in the sun. So there are ways to have fun in the sun, as long as, just like this cute little baby here, you remember what's important when you're out in the sun. Wear your wide brim hat, wear your sunglasses, wear your sunscreen. If you feel like it's too much, seek shade, go somewhere where, you're going to be protected from the sun. And always, if you find a lesion that is not behaving normally, you have a spot that is persistently bleeding for like a week or 2 weeks, or a scab that will not heal for a couple of months, even if you don't pick at the scab, then you want to make sure that you have it evaluated. All right, that was kind of it for me. And then we're going to open the floor to questions. Thank you for having me.
All right, the question we have here is there anything specific that people with Parkinson's should look at as it relates to dermatology?
So as far as Parkinson is concerned, I know the literature, in the literature it says they're a high risk for melanoma. Even though that's the case, basal cell is still the most common type of skin cancer that's diagnosed. So meaning, if you've never had a skin check, it's important to have a skin check because your disease just puts you at risk for a skin cancer, right? So once you have somebody look at you all over the first time, then they can determine if there's anything that they want to keep an eye on. So I think just baseline, okay, I have melanoma, I have Parkinson's. So because of that, I want to make sure that there's nothing on my skin that I need to keep an eye on. So let me go see somebody to look at it and then tell me. Then once you have that baseline exam, then first you can ask questions, hey, this part, or what should I be looking at? What changes should I be looking for? So yeah, I would say just get that baseline skin check.
The next question along the same lines is, how does Parkinson's affect the risk of skin cancer?
So the literature, the studies have shown that there's a correlation, right? So it's not Parkinson, it's not causing the skin cancer, but they've noticed that most patients that have, Parkinson have a higher risk of getting melanoma. So meaning Parkinson is another risk factor for you. So because of that, again, what we can change is our behavior, right? Vis-a-vis the UV rays. We can't change the fact that we have Parkinson or we're old, right? So that's why we always say UV protection is the number one thing. That's something that we can do, we can change to help minimize the risk, or kind of remove that risk factor from our list of all the things that is against us.
I want to thank Dr. Dika again for that presentation. I know I will be going out and buying a new moisturizer with some higher sunscreen.
Definitely. And you will fun quiz, right? We had a fun quiz that we could go through if you know.
Oh yes, yeah. Raven, do you want to share the quiz?
And if people can just type in their answers, A, B, C, or D, or A, B, C, D, E. So the first question reads, how often should you reapply sunscreen when you are outside? Is it at least every hour, at least every 2 hours, at least every 4 hours? Don't need to reapply, or only need to reapply after sweating or swimming?
Somebody answered letter B.
Correct. Yeah, so that's usually the recommendation. Every 2 hours, we apply sunscreen. So the next question is, a recent FDA study showed that some sunscreen ingredients are absorbed into the body. That means, or this means, I should continue to use sunscreen as directed. Evidence of absorption doesn't mean these ingredients are unsafe. It just means that more data is needed. Or is it B, I should stop using sunscreen? C, I should make my own sunscreen? Or D, I should only use sunscreen conservatively, for example, only in limited amounts on a sunny day?
I think we all know the answer to this one. And someone typed in A.
Yay. Correct. This is where it says SPF 15, and honestly, currently we recommend SPF 30. And then here also it says between 10 and 2 p.m., 4 p.m. Just change that in your mind. Which of these statements is true regarding sun safety for infants? Well, I guess we didn't really talk about it, but adults are at greater risk than infants of sunscreen side effects such as rash. Infants can be exposed to the sun for a limited amount of time without increased risk. Sunscreens are not recommended for infants under 6 months of age. Protective clothing does not have much effect on sunscreen, and sunscreen is a much better UV protection method. Should I just answer since we didn't even talk about it?
Someone gave it an answer, and they're choosing A.
Yeah, the answer is C. So apparently sunscreen is not recommended for infants under the age of 6 months. All right, so the FDA recommends that you do not use sunscreen products that have passed their expiration date. If there is no expiration date indicated, what should you do? not use it, report it to the FDA, assume it is stable to use if it was purchased within the last 3 years and has been stored in a cool, dry place, or assume it is stable to use indefinitely. A few people have raised their hands. Do we want to pause the quiz and
Sure. Let's see. Go ahead if you got a question or have an answer. Chris? Chris, you can unmute and ask your question, or John. Okay, I guess you can go on to your next question.
okay, so the answer here would be C. Right, so meaning if there's no expiration date on the sunscreen, just if you just bought it, it hasn't been 3 years, it's okay to use it.
Oh, it looks like Chris is ready to.
Okay, great. I was wondering if you're applying every 2 hours, if that also is in regard to if you're using 45 or 70 sunscreen?
Correct, yeah. Any sunscreen that you're using, we apply every 2 hours, meaning after the 2 hours, just everything else that you had put on your skin, it lost like the effect on the skin.
Okay, thank you.
You're welcome.
You.
Okay, the next question is, all of these are ways to reduce risk of sun damage to your body, except limiting your time in the sun, especially between 10 and 2 p.m. when the sun rays are most intense. Wearing clothing to cover skin exposed to the sun, such as long sleeve shirts, pants, sunglasses, and broad brim hats. Using broad spectrum sunscreen with SPF value of 15 or higher regularly and as directed, or getting a base tan by using tanning beds or laying out in the sun.
based on you laughing, I think we know the answer. It's not D. No one has answered. I'll let you answer that for them.
So D is the answer. So everything else is correct.
Oh yes, except.
Yeah. Okay, true or false? All sunscreens protect against sunburn, but only those that are SPF 15, again, 30 for me, or above, and broad spectrum have also been shown to reduce the risk of skin cancer and early skin aging.
True. Someone answered.
Okay, another true or false. If you sweat or go swimming, you need to reapply sunscreen more often than every 2 hours, even if the sunscreen is water resistant.
True.
Okay. When do the FDA and CDC recommend wearing sunscreen? Is it while swimming, at the beach on a sunny day, while playing outside on a cloudy day, while hiking in the winter, or is it all of the above?
We have an answer of D.
Yeah, we were talking about a cloudy day earlier, right? Even in the winter.
Exactly.
Yeah. Okay, another 12 false. Getting a tan, whether you have lighter or darker skin, is healthy. Yeah, false. Any color change is a sign of skin damage in any skin type, so getting a tan is not a good thing. Last question. A sunscreen label of SPF, sun protection factor 15 means. Oh, that one is a tough one. You can stay out in the sun 15 times longer than you normally can without getting burned. The sunscreen lets twice as much solar radiation through as a sunscreen label SPF 30. It takes 15 minutes more solar energy to produce a sunburn compared to unprotected skin. The SPF value tells consumers how much broad spectrum protection the sunscreen provides, or you can stay out in the sun for 15 hours without getting burned.
Anybody gonna try to answer that one?
This one is C.
Yep, good job, Fred.
Oh, okay, somebody got, okay.
Yep, someone chose C.
So the answer is C. That's just a definition of SPF. All right,
Did we pass?
you did great. That's 80%, that's fast, right?
That's passing in my book.
That's a P.
So thanks again, everybody. Enjoy the rest of your beautiful sunny afternoon, and we appreciate your time today.
Thank you, everybody, thank you.
Bye-bye.
Bye.